The ambulance doors open and a man is rolled into an American emergency room. He is pale, confused, and struggling to breathe. A nurse can ask his name. She can ask what happened. But before the hospital decides whether he is having a heart attack, it cannot make his care depend on the answer to one financial question: how are you going to pay? Today that feels like the minimum meaning of an emergency room. In 1985, it was not a uniform federal guarantee. Hospitals did not simply abandon every poor patient before 1986. Public hospitals treated millions. Religious institutions offered charity. Doctors often cared for people who could never pay them. Some states and cities imposed duties of their own. But the protection depended on where you collapsed, which door the ambulance reached, and what that hospital believed it owed you. There was no single federal rule requiring most emergency departments to examine every person who came through the door and stabilize an emergency condition regardless of money. The result produced one of the darkest phrases in modern American medicine: patient dumping. A hospital might refuse an uninsured patient, perform only a cursory examination, or transfer someone who was still bleeding, in labor, or dangerously unstable to a public facility miles away. The ambulance did not always move the patient because another hospital offered better medicine. Sometimes it moved the patient because another hospital was expected to absorb the bill. So how did the emergency room become a place where the medical question had to come before the financial one? The answer begins when hospitals were not places most Americans wanted to enter. It passes through charity wards, federal construction money, the creation of Medicare and Medicaid, a new financial pressure that turned sick people into unpaid accounts, doctors at a crowded Chicago hospital who began counting the bodies arriving at their door, and a few pages hidden inside a massive budget law. To understand what changed in 1986, we have to return to the world before the emergency room. In the early 19th century, a respectable American family usually expected serious care to happen at home. Hospitals existed, but many served people who had nowhere else to go: the poor, sailors, immigrants, the contagious, and the dying. They offered shelter and nursing as much as scientific treatment. Entering one could signal not only sickness, but social failure. That changed as medicine became more capable. Anesthesia made complex surgery more practical and bearable. Antiseptic practice made it safer. Laboratories, X-rays, blood banking, and specialized equipment gathered under one roof. Hospitals could now do what no bedroom or traveling doctor could reproduce. The institution once associated with poverty became both a center of modern expertise and an expensive business. But the old division never disappeared. Cities and counties operated public hospitals for people private institutions did not serve. Religious hospitals maintained charity wards. The arrangement provided real care while creating a dangerous assumption: someone, somewhere, would always be the hospital of last resort. In 1946, the Hill-Burton Act helped communities build and modernize hospitals. Facilities receiving its funds were required to provide a reasonable amount of uncompensated care, and thousands of communities gained new beds and operating rooms. But Hill-Burton was not a universal promise that every emergency patient at every hospital would be examined and stabilized. Its obligations were limited and often difficult for patients to understand or enforce. Then came Medicare and Medicaid in 1965. Medicare brought hospital insurance to older Americans. Medicaid helped cover certain people with low incomes, although eligibility varied by state. The programs transformed access and hospital finance while leaving a large group exposed. Working-age adults who were not old enough for Medicare, did not qualify for Medicaid, and had no insurance through a job. America had built more hospitals and found ways to pay for millions of patients. It still had no uniform answer for the uninsured person arriving tonight. Imagine one of them in 1984. He is 38, employed by a small contractor, and has no health plan. A crushing pain begins behind his breastbone. His wife drives him to the nearest private hospital because it is only 5 minutes away. At the desk, the emergency is also an account. If he is admitted, tests, physicians, drugs, and a hospital bed may cost thousands of dollars. If he cannot pay, the hospital may never recover that money. The people confronting him are not necessarily cruel. The nurse may want him treated immediately. The emergency physician may understand the danger. But hospitals live inside budgets, and budgets turn moral choices into institutional incentives. A private hospital that accepts every unpaid case can lose money while another hospital transfers those cases away. A county hospital funded by taxpayers cannot easily close its doors. The more faithfully it serves as the safety net, the more expensive and crowded that role becomes. During the late 1970s and early 1980s, hospital costs rose and competition intensified. Payment systems became more disciplined. In 1983, Medicare began shifting most short-stay hospitals toward fixed payments based largely on a patient's diagnosis, rather than simply reimbursing every reported cost. That reform was designed to control spending and reward efficiency. But across the industry, the financial identity of a patient was becoming harder to ignore. A person with good insurance represented expected payment. An uninsured emergency represented uncertainty. There were many ways to make that uncertainty disappear. The patient could be told the hospital lacked the appropriate specialist. The ambulance driver could be directed toward the county facility. A woman in labor could be described as stable enough to travel. A brief examination could become evidence that no emergency existed. The paperwork might say transfer. The receiving hospital might call it dumping. The distinction matters. Hospitals transfer patients for legitimate reasons every day. A small facility may not have a burn unit, a trauma surgeon, or a neonatal intensive care unit. Moving a patient to specialized care can save a life. Patient dumping occurs when the transfer is driven by the person's inability to pay, or when a hospital sends a patient away without the examination, treatment, consent, records, receiving agreement, and medical precautions a safe transfer requires. From the private hospital's perspective, the patient was a financial risk being moved to the institution designed to carry it. From the public hospital's perspective, the patient often arrived after valuable time had been lost. The destination inherited both the medical crisis and the unpaid bill. The patient, meanwhile, might never understand why the first hospital could not help. He knew only that the ambulance doors had closed again while his body was failing. By the early 1980s, doctors at major public hospitals were seeing a pattern too large to dismiss as misunderstanding. Transfers into public facilities rose sharply in several cities. Published figures showed medically transferred patients in Chicago increasing from about 1,300 in 1980 to more than 5,600 in 1984. In Washington, D.C., the reported annual number grew from 169 to 930 between 1981 and 1985. In Dallas, transfers climbed from roughly 70 a month in 1982 to more than 200 a month the following year. Numbers like these could still be explained away. Perhaps the patients truly needed specialists. Perhaps public hospitals simply offered services smaller institutions could not. So researchers examined what happened to the people themselves. At Cook County Hospital in Chicago, a team including physicians Robert Schiff and David Ansel prospectively studied 467 medical and surgical patients transferred from other emergency departments. They found a system operating less like a network of coordinated care and more like a financial sorting machine. Most patients lacked insurance. Many were sent despite being medically unstable. The researchers concluded that the transfers were predominantly economic. The human reality inside that conclusion was terrifying. An unstable patient is not a package whose condition pauses during transportation. Blood pressure can collapse in the back of an ambulance. An airway can close. A fetus can lose oxygen. A person with internal bleeding can spend the most important minutes of his life moving between institutions, while each institution debates responsibility. The problem was especially visible in childbirth because labor created both urgency and ambiguity. A hospital could claim that a woman was not yet close enough to delivery, or that another facility was better prepared to accept her. But labor does not follow an administrator's schedule. Women without insurance were sometimes sent away after contractions had begun, forced to travel farther, while the risk to mother and child increased with every mile. In December 1985, an Alameda County woman named Sharon Ford went into labor. Ford was covered by Medi-Cal California's Medicaid program, but a computer record mistakenly showed that she had no insurance. 2 private hospitals turned her away. Hours later, at Highland General Hospital, the county facility, her baby was born dead. No surviving account can establish whether faster care would have changed that outcome. But the case exposed something disturbing enough on its own. While a woman was in labor, an incorrect financial record helped determine which doors opened and how much farther she had to travel. Ford's name gave the national argument a human face. She was not uninsured. The computer was wrong. Yet the medical consequences of that error could not be paused while the record was corrected. Statistics showed how large patient dumping had become. Her journey showed what financial sorting felt like from the patient's side of the hospital door. Trauma created a different version of the same trap. A public hospital might have the region's strongest trauma team, making transfer medically reasonable. But that legitimate fact could become convenient cover. If nearly every uninsured accident victim was sent to the public center while insured patients with comparable injuries remained, the system was not merely directing expertise. It was directing debt. This was not a story with one obvious villain. Private hospitals argued that they could not finance unlimited charity care. Public hospitals argued that they could not safely absorb every unwanted patient in a region. Doctors argued that administrative decisions were interfering with medical judgment. Ambulance crews were placed between institutions. Taxpayers financed the destination. And the uninsured patient carried the consequences of a system in which everyone could explain why someone else should pay. Medical ethics offered a principle, but ethics alone did not create a reliable right. State laws varied. Court decisions could impose duties in particular circumstances. Hill-Burton obligations reached some federally funded facilities. Accreditation standards and professional expectations mattered. Yet a frightened family at midnight could not build a legal argument from that patchwork while a person was turning blue in the parking lot. The missing element was a clear national sequence. First determine whether an emergency exists, then stabilize the patient or arrange a medically appropriate transfer. Ask who will pay, but do not allow that answer to decide whether the first two steps occur. Simple as that sounds today, imposing it across American emergency departments meant changing who carried the financial risk. Public outrage grew as newspapers, physicians, and congressional hearings turned cases like Ford's into stories the country could see. The phrase patient dumping made the act impossible to disguise. Hospitals were not merely transferring cases. The country was accused of dumping human beings. During the debate, Republican Senator David Durenberger of Minnesota argued that Americans, rich or poor, deserved access to quality health care. Congress responded in an unusual way. The new protection did not arrive as a grand national health program with a famous name and a ceremony built around it. It was included in the Consolidated Omnibus Budget Reconciliation Act, commonly called COBRA, signed on April 7, 1986. Inside that enormous budget legislation was a provision that became known as the Emergency Medical Treatment and Labor Act, EMTALA. Its reach came from Medicare. Hospitals that participated in Medicare and operated emergency departments would have to follow federal emergency care obligations. Because nearly every major American hospital depended on Medicare, the condition reached far beyond older patients. The protection applied to the uninsured construction worker, the pregnant woman on Medicaid, the child visiting from another state, and the wealthy traveler whose wallet could not be found. Later amendments and regulations refined the details, but the core sequence began here. The first obligation was an appropriate medical screening examination. If a person came to the emergency department requesting examination or treatment, the hospital had to evaluate whether an emergency medical condition existed. Registration could still happen. Insurance information could still be collected as long as it did not delay the examination or treatment. The hospital could not use a thin wallet as a substitute for a medical conclusion. Return to the 38-year-old man with chest pain. Before the law, a hospital might redirect him before discovering whether he was having a heart attack. Under EMTALA, the hospital must provide the screening it ordinarily uses to determine whether an emergency condition exists. The promise is not that every person receives every available test. It is that the hospital must make a genuine medical assessment without screening the insured one way and the uninsured another. The second obligation was stabilization. If the examination revealed an emergency condition, the hospital had to provide treatment necessary to prevent a dangerous deterioration within its capability. For a woman in active labor, stabilization generally meant delivery unless a safe transfer could be arranged. For a person whose airway was closing, it meant addressing the airway before discussing where the bill belonged. Stabilization did not mean curing every illness. It did not require a community hospital to perform a transplant or provide months of cancer treatment. It meant that when a dangerous condition existed, the patient could not simply be pushed back through the door because payment was uncertain. The emergency had to be brought under control as far as the hospital's staff and facilities could reasonably manage. The third obligation governed transfers. If the hospital lacked the capability to provide the necessary care, it could still move the patient. But the transfer had to be medically appropriate. The expected benefits had to outweigh the risks. Available treatment had to be provided first. Relevant records had to travel with the patient. Qualified personnel and suitable transportation had to be used, and the receiving hospital had to agree to accept the person. The law also addressed a quiet form of refusal at the other end of the telephone. A hospital with specialized capabilities and available capacity could not refuse an appropriate transfer merely because the patient lacked money. A burn center could not protect itself by leaving an uninsured burn victim at a hospital unable to treat the injury. Responsibility now extended across the chain of care. EMTALA was powerful partly because the federal government could enforce it through civil penalties and the hospital's Medicare participation. Physicians could also face consequences for improper transfers. The law transformed emergency access from a charitable preference into a condition attached to the financial bloodstream of American hospitals. The requirement took effect on August 1, 1986. At almost exactly the same moment, researchers in Memphis were documenting how deeply the old practice remained embedded. Between June and August, they recorded transfer requests from private emergency departments to the Regional Medical Center, the city's publicly subsidized hospital. In 164 cases where a reason was recorded, lack of money or insurance was explicitly identified as the primary reason 89% of the time. The study straddled the moment the federal rule took effect. It captured the old system not as a memory, but in the act of meeting the law intended to change it. But the law did not make emergency medicine free. After the screening and treatment, the bill could still arrive. A patient stabilized after a heart attack could owe thousands of dollars. EMTALA did not provide insurance, long-term medications, a regular doctor, or unlimited care after the emergency ended. Nor did it create a matching federal payment for every uninsured patient hospitals were now required to treat. The law changed what could happen before the patient was safe enough for money to become the argument. It did not settle who would ultimately bear the cost. That produced a Central American paradox. EMTALA guaranteed access at the most expensive and dangerous moment, when illness had already become an emergency. It did not guarantee the insulin that might prevent the crisis, the blood pressure medicine that might prevent the stroke, or the specialist visit that might detect cancer sooner. Emergency departments became the one doorway people knew could not close simply because they were poor, while safety net hospitals continued carrying a disproportionate burden. The country created a legal floor beneath catastrophe without building a complete path above it. The law did not require every visitor to be admitted. It required an appropriate screening to find out whether an emergency existed. A hospital could determine that a condition was minor. What it could not do was assume the condition was minor because the patient was poor. Nor did patient dumping vanish in 1986. Laws do not monitor triage desks by themselves. Investigations over the following decades found hospitals that failed to screen, failed to stabilize, or refused appropriate transfers. Some violations came from confusion. Others came from overcrowding, inadequate staffing, or financial pressure. EMTALA made the conduct illegal and punishable. It did not remove every incentive that had created it. The law also forced Americans to confront a difficult boundary. At what moment does a private institution acquire a public duty? Hospitals are employers, property owners, and organizations that must balance revenue and expense. But an emergency department occupies a special place. A person who arrives unconscious cannot compare prices, negotiate terms, or drive to a cheaper competitor. The ordinary logic of a marketplace collapses when the customer may die before making a choice. That is why the law changed more than hospital procedure. It changed the meaning of the emergency room sign. The glowing letters came to represent a promise that did not depend entirely on charity or on a clerk deciding whether an account looked collectible. The promise was limited, expensive, and imperfect, but it was national. If you want to understand the systems that quietly govern ordinary American life, subscribe. Return once more to the ambulance at the beginning. The man has no insurance card in his pocket. His wife does not yet know how the family will pay. The hospital may eventually send a bill they cannot afford. It may transfer him if he needs treatment available somewhere else. It may stabilize him and discharge him into a system where the next appointment remains uncertain. None of that is small. But the emergency team must first look for the heart attack. If it finds one, the hospital must use the capability it has to keep him from dangerously deteriorating or arrange a safe transfer. His bank balance can shape what happens after the emergency. It is not supposed to decide whether the emergency is recognized. Before 1986, that sequence was not guaranteed by one federal rule. A patient could arrive at the nearest hospital and discover that the institution was examining the wallet before it fully examined the body. EMTALA did not create universal health care. It did not erase medical debt. It did not make every hospital equal, and it did not end every improper refusal. What it did was draw a line at the emergency room door. On one side, hospitals could still argue about insurance, reimbursement, charity, and cost. On the other, a human being with an emergency had to be screened and stabilized before inability to pay became the reason to send him away. America did not make emergency medicine free. It made the emergency room door harder to close.